Thank you so much for joining us this morning. My name is Vivian Ho. I'm a health economist here at the Baker Institute, and I'm also director of the Center for Health and Biosciences. Today's conference is going to focus on policy and social impediments which limit our ability in the United States and Mexico to combat emerging and neglected tropical diseases such as Chagas, dengue, and leishmaniasis. Last night's conference keynote speaker, if you were here, it was a terrific speech by Dr. Mitchell Wolfe, who's Deputy Assistant Secretary of Global Health in the U.S. Department of Health and Human Services. He spoke about U.S. efforts to combat disease and poverty at the U.S.-Mexico border. In addition, we hosted a workshop yesterday for students on neglected tropical disease awareness and advocacy. Now, today's distinguished guests, and it's an impressive list. I'll just name some of a few, but our distinguished guests are the Mexican Secretary of Health, Dr. Mercedes Juan Lopez, Dr. Roberto Tapia Conyers, who is the Director General of the Carlos Slim Foundation, and our state legislator and strong advocate for health, Sarah Davis. Before we introduce our first presenter, I'd like to thank all of the program collaborators who worked with us on this conference: the Baker Institute's Mexico Center, the END Fund, the Baylor College of Medicine's National School of Tropical Medicine, the Texas Children's Hospital Center for Vaccine Development, and the Sabin Vaccine Institute. I'd also like to thank Bert and Dee Dee McMurtry, who sponsored our student awareness competitions. And finally, of course, the AbbVie Foundation, who sponsored this week's events and the center's work on U.S.-Mexico disease and poverty. To talk about the AbbVie Foundation, I'd like to invite up here for just a couple of minutes the AbbVie Foundation Director and AbbVie's Director of Corporate Responsibility, Dr. Veronica Aravalle.
Thank you. Well, welcome on behalf of the AbbVie Foundation, the philanthropic arm of AbbVie. We're proud to be a sponsor of today's event. This is important discussion, collaboration, and hopefully we have collective action that comes out of this. A special thank you to Baker Institute and the Baylor School of Tropical Medicine, and a special thanks to all of you who have a shared commitment in this space, and that for those working both in the U.S., Mexico, and a shout out to those working globally as well. So while the AbbVie Foundation has no commercial interest in the NTD domain, we recognize the need is great. We heard yesterday that there were 1.4 billion people suffering from one or more NTDs, 2 billion from soil-transmitted helminths, and the numbers are startling. Both the AbbVie and the AbbVie Foundation are leveraging our scientists, our science, our talent, our compounds, and our dollars, our philanthropic dollars, to really meet the greatest needs of those in the underserved. A few examples include working with more than 100 of our AbbVie scientists. Our most experienced scientists are contributing to drug discovery and development in initiatives with NGOs and other schools of medicine and tropical medicine. So look, working with DNDi, working with the TB Alliance, working with the Medicines for Malaria Venture. And a lot of these initiatives are really about having our scientists contribute their time, and as part of what our VP of Corporate Responsibility and Public Affairs often says, this isn't their day job. They're doing this because they recognize the need, not because we have a pipeline, not because we have a commercial interest, but because we really want to contribute to a very important space and very important dialogue. So we anticipate growing in Latin America and making more investments in the NTD space. You know, on the philanthropic side, AbbVie Foundation has a special interest in Latin America. A partnership with MAP International on prevention and control of Chagas in Bolivia, a partnership with Sabin Institute, providing programmatic support for Mexico and looking at an STH evaluation with PAHO, working in 10 cities, collecting information to do an evaluation of STH national program. Working also in Colombia on soil-transmitted helminths in 18 villages, my native country. So working, side by side with the ministries of health and with NGOs in those countries to really look at tackling and combating and uniting for NTDs. In short, I'm proud of the work that AbbVie and the AbbVie Foundation are doing to take the neglect out of tropical diseases. So to echo Dr. Peters Hota's famous line, on a personal note, let me add that the honor of working directly with MAP International in my previous life, working to combat NTDs, both in Africa, sort of on the ground in Africa and Latin America, really taught me that the importance of this work, and knowing that there are scientists, governments, academics, NGOs, and foundations alike that are interested, focused, and dedicating their time and energy and dollars to invest in this is a very important opportunity. I've learned a lot already from the opportunity that we have. I hope to learn a lot more and to hear the opportunities that exist going forward to continue this dialogue. And I look forward to our collective learnings turning into action. So again, thank you and welcome.
Thanks so much, Dr. Arayave. Before I introduce our first speaker, I did want to take just a minute to present awards to our winners of the 2015 Neglected Tropical Disease Student Challenge. If they would just come up here, I'd like to give them their certificates. They're Jennifer Wynn and Emmy Sun. Congratulations. And congratulations. Now I'd like to introduce our first speaker, our well-known Dr. Peter Hotez. Dr. Hotez is an internationally recognized physician scientist and the Baker Institute Fellow in Disease and Poverty. He leads our policy efforts around neglected tropical diseases globally here and here in Texas. Dr. Hotez is also the Dean of the National School of Tropical Medicine at Baylor College of Medicine and Texas Children's Hospital Endowed Chair of Tropical Pediatrics and President of the Sabine Vaccine Institute. Please join me in welcoming Dr. Hotez.
Thank you so much, Vivian, and again, thanks to Veronica and the AbbVie Foundation for their generous support and intellectual backing of this important conference. And I'd also like to thank especially Dr. Jennifer Herricks and Kristen Matthews, who I know spent an enormous amount of time and effort helping to organize this and put a lot of thought into what we really want to say when we talk about this shared legacy of disease and poverty in Mexico. First of all, how many people are coming to the Baker Institute for the first time? Raise your hand. So quite a number. So I think if you have the time, please walk around the Baker Institute a little bit. You really and look at some of the photos and some of the writings. I think when you come here, one of the things that first struck me when I moved to Houston 4 years ago was this is a place that's really at the center of the intellectual horsepower of the state of Texas, and you really get an appreciation of the power of the state of Texas when you spend some time here. It's just a fabulous building, and it's a fabulous set of people to work with here at the Baker Institute. What I want to do is kind of set the stage and tell you what we're talking about when we talk about a shared legacy of poverty and disease. The way I'm going to start it is going back to basics, which are these set of 8 goals that are known as the Millennium Development Goals. So what happened was, this week we have the UNGA, the United Nations General Assembly, going on in New York. I was there yesterday at the Clinton Global Initiative speaking, and was lucky to get out alive with this level of security. And the whole island of Manhattan is in a state of gridlock, and I had to go through great heroics to get to Newark Airport in time. Well, 15 years ago, we were at a similar set of circumstances where we brought where Kofi Annan, who was then Secretary General, brought all global leaders to United Nations headquarters to draft these 8 goals to lift the plight of the billion people on the planet who have no money, and to really look at what are the causes of poverty. And I think one of the more forward-thinking components of this was linking health to poverty. And this came out in part because shortly before this, Gro Brundtland, who was then Director General of the WHO, had commissioned Jeffrey Sachs to launch a commission on macroeconomics and health that really, in a very, with surgical precision, really pinpointed why disease not only occurs in the setting of poverty, but reinforces poverty. Now, I'm not a big fan of United Nations documents. I think most of them are forgotten as quickly as they're drafted. But this one has stuck and has provided this important overarching framework. And it also created a buzz and brought all these beautiful people involved in global health to get people to care about it. So you had Brad Pitt doing a 4-part series on the Millennium Development Goals for PBS, and you get Brad, of course you get Angelina, and then you got George Clooney involved with the Millennium Development Goals and Christy Turlington. And this all created a lot of excitement and energy, and especially important was the fact that it brought money to the table. So this is the enormous swelling of overseas development assistance that began as a consequence of the Millennium Development Goals, and a lot of it was from the United States government through USAID and the President's Emergency Plan for AIDS Relief that was launched by President George W. Bush shortly after the Millennium Development Goals and the Global Fund. And the question is, what's been the impact? Has it made a difference? Well, we're now in a position to look at what those dollars have done, because what happened was Bill Gates a couple of years ago funded an initiative that we're part of here at the Baker Institute, but it's based in Seattle, Washington, to be next to the mothership, and it's known as the Institute for Health Metrics and Evaluation, and it's headed by this charismatic individual in the lower right-hand corner, Chris Murray, we're really trying to get a sense of, did all that overseas development assistance coming from the U.S. government, from the UK government, from the EU, from really all the G7 countries, really make a difference in the years following the Millennium Development Goals? Because we need to know that, because we're going now into year 15 of it, and the MDGs are now sunsetting, and we're reinventing them as a new set of sustainable development goals. So what has been the impact? So let's look at a couple of things that's happened. This is Millennium Development Goal number 6, which I think has probably had one of the most far-reaching effects of the Millennium Development Goal to combat HIV/AIDS, malaria, and other diseases. This is what was spent with millions of overseas development assistance to put people on antiretroviral drugs in sub-Saharan Africa and India who never saw them before, to give people anti-malarial drugs and bed nets. And we'll come to the other diseases component in a minute. So how do we know if it's working? Well, we've been really doing an in-depth analysis under the auspices of the Institute for Health Metrics and Evaluation. And it's a big effort. This is one of our papers that we've written. This is half the author list. It looks like a paper coming out of the CERN physics laboratory. I don't know if I have a pointer here. I think I'm somewhere in here. It's a little bit like Where's Waldo? It's I'm somewhere in the middle there. And what has been the impact of, for instance, of all the overseas development assistance for HIV/AIDS and malaria and other diseases? Well, there's an effect. So one of them is the fact that prior to the Millennium Development Goals and all that ODA, there was a steep rise in the number of people newly infected with HIV/AIDS and the number of deaths. But look at that, the curve flipped, it turned over. And that can clearly be shown to be a result of putting people on antiretroviral drugs throughout sub-Saharan Africa, India, and elsewhere. And the estimates are 19 million lives saved. And we went from a peak of 1.7 million deaths annually down to 1.3 million deaths annually. That's important because, remember, you're now going back to a very contentious Congress wanting to know, is this going to have an impact? And you need those kind of hard numbers to go back and say this is worthwhile. And for for malaria, we've seen a 30% reduction in the number of malaria cases and a 30% reduction in deaths. And so this was, again, having a steep curve that we've now flipped over. Now, still a lot of people are dying of malaria, 855,000 deaths annually, but it is making a big difference. Now, the problem with the Millennium Development Goals, among the problems, was the third component. They called them the other diseases, and And calling something other diseases from an advocacy perspective, for those of us who work on other diseases, was, you can imagine, an absolute disaster, right? Because you're not getting Brad and Angelina standing up there saying other diseases now, right? So it wasn't happening. And so those of us who were working on the other diseases got together and decided that we need to get out of our comfort zone as scientists and physicians and get involved in a little branding exercise, which is what we did. We actually made up a term. We call them the neglected tropical diseases, which is a term that really first appeared in the biomedical literature in 2005, where we put together these 13 or 14 tropical diseases that we recognized were highly prevalent among the poor. They often were not killer diseases, but they were chronic and disabling conditions. And many of them produce disfigurement, so they're highly stigmatizing. And the last point was very important, that last bullet point, which is that they're poverty promoting. They both occur in the setting of poverty, and they reinforce poverty through their chronic and debilitating effects. And we really made an all-out push to make people care about these diseases. So I wrote this book, which in the upper right-hand corner, which my kids, as only loving kids could do, used to call Dad's Forgotten Book on Forgotten People with Forgotten Diseases. But it has now gone into its second edition, and we just had an event in Japan. It got translated into Japanese by the University of Tokyo Press. So I like to think we're making progress. So how are we doing in terms of number of people infected? So we went back to the subset of authors who were interested on other diseases, and we quantitated them, to see what are the most common afflictions of the world's poor. And here's the number one disease of poor people: Ascariasis, intestinal roundworm infection. Incredible numbers. Basically, all of the bottom billion are infected with Ascariasis or whipworm infection or hookworm disease or schistosomiasis. And because these add up to more than 1 billion people have multiple infections at the same time. Foodborne trematode infections. Here's dengue, lymphatic filariasis, onchocerciasis, Chagas disease, leishmaniasis, trachoma, cysticercosis, echinococcosis, rabies, African trypanosomiasis, Yas-Buruli ulcer. Here's Ebola virus, which for the year 2013, which is our latest number, we don't have any evidence of Ebola virus infections. This will change for the next time around. The point is, every single person living in poverty has one or more of these diseases. Oftentimes, these are not killer diseases, but they're highly debilitating. And that's not an easy message to get across. So let's look at what happened in West Africa this past year, in Guinea, Liberia, and Sierra Leone, where you had 20,000 cases of Ebola virus infection, which was actually less than 0.1% of the population. One of the things we tried to get across, yes, Ebola is important, but while Ebola is affecting less than 0.1% of the population, absolutely everybody has schistosomiasis or hookworm or malaria or some combination of the three, and more than half the population basically is infected by those three diseases, which often occur in tandem. And these are really the diseases that are devastating places like in West Africa, but it's a hard message to get across. So working with Jennifer Herricks here at the Baker Institute, we've been trying to see what kind of numbers we can come up with to get people to care about these diseases. And I think one of the messages is the fact that they reinforce poverty. And how do we explain that? Well, this is one metric that we've come up with, which is we've developed a national worm index for a country, which is the number of your kids infected with intestinal worms or schistosomes, or adults and children with elephantiasis. And then we divide, and these are using WHO numbers, then divide it by the population of the country. And this is showing that as your worm index goes up, your human development index, which is a metric put out by the United Nations Development Program to look at life. It's a complex metric that includes life expectancy, years of educational attainment, how you treat girls and women in your country. And this basically shows that there's an inverse relationship. As HDI goes down, worm index goes up. Well, Jennifer and I had a difficult time getting this paper accepted because the reviewers wanted to know, well, which is the chicken, which is the egg? Does the worms lower human development, or does low human development create worms? And the answer, we said, is both. We think it's yes, as to that we think that things flow both ways. So this is really showing that these are the stealth reasons. These and other metrics are showing that the neglected tropical diseases are the stealth reasons why people can't escape poverty. So going along the line of being a scientist advocate, we wrote about this problem of neglected tropical diseases in the Public Library of Science in 2 back-to-back papers in 2005. And here's where we got kind of stuck. And this is why, it's a great example of why we need something like a Baker Institute, because as a scientist, you're trained to, you write your papers, and then you use that to get your grants, so you can write more papers, so you can get more grants, so you can write more papers, so you can get more grants. But the concept of being a scientist and then pushing a political agenda is not really something that's in our DNA. And that's why I think we're going to have to look at greater public engagement by scientists. I like to quote this interesting study that was done by my colleagues by Research America, which is a policy think tank in D.C., that did a survey that found that 74% of Americans cannot name a living scientist. Of the 26%, who was the most number one named scientist? Who could name a scientist? Anyone make a guess? Stephen Hawking was number one because it came out after the movie. Number two? No, he wasn't actually. Well, no, I don't think he was. Number two was Bill Nye the Science Guy. So, and I think James Watson was third. And then 60% of Americans cannot name an institution where biomedical research is conducted. And only 9% of Americans ever heard of the NIH. By the way, there's not a single institution at the Texas Medical Center named. And I like to say that that's our fault as scientists, that we're so focused on the grants and papers, that we've gotten totally away from public engagement. Well, this was an example of getting out of our comfort zone because we had no Brangelina, right, to champion other diseases. So we had to do it, and we worked with the White House under George W. Bush. And I didn't know it at the time, but I had gotten lucky because the Bush White House had just launched PEPFAR, the President's Emergency Plan for AIDS Relief, and they were so excited by the early results that they were looking for another big picture program. And we'd come up with this idea of packaging all these diseases together in order to target them with a package of medicines that were being repurposed from the major pharmaceutical companies. So for instance, Zithromax, which we all take for our upper respiratory infection, also works to eliminate trachoma. So we've got this whole program in place to create this package of medicines. And this is what you can do as a science advocate. Right after we wrote the papers, we got $15 million appropriated through Congress, and now we're up to $100 million. That's not a lot of money in today's economy, but we were doing these packages for 50 cents a person per year. So we were getting now 200 million people treated annually. USAID just celebrated its billionth person treated. So no, 450 million people have been treated, but it's 1 billionth treatment. So extraordinary what you can do if you're willing to take the time to do that kind of public engagement. The problem, of course, is we also need new innovations as well. And one of the things that we're doing with Baker and the Texas Medical Center, and this is working with Mary Elena Bottazzi, who's leading a lot of our product development efforts, is we're making now a new generation of vaccines for these diseases in the nonprofit sector because the big pharmaceutical companies are not going to take an interest in making them. So that's a very long introduction to the reason for this conference. So a key reason for this conference was as part of the efforts from the Institute for Health Metrics to see where neglected tropical diseases are, our first thought was this was all going to be about Africa, and oh yeah, a little bit of South Asia. But we really were surprised to see the geographic diversity of these diseases. Yeah, they're in Africa, but they're everywhere else in the world. And this is just a barcode of the different diseases and where they occur. And when we really did a deep dive in the numbers, what we found was pretty amazing. And this is all work done since coming here to Houston, working with the Baker Institute, that most of the world's neglected tropical diseases are not in the poorest, most devastated countries. Most of the world's neglected tropical diseases are in the poor who live amidst wealth. So let me explain this. So what I'm showing you is a map of the G20 countries. And we added Nigeria as well, because although it's not a G20 country, its economy is bigger than 3 of the bottom G20 countries. And what I'm showing you is a map of where poverty occurs in the G20. So if you go into China, for instance, anyone who's been to Shanghai or Beijing is impressed by its power and wealth. But if you go into Western China, you go into Guizhou, Sichuan province, you go back in time 100 years and you see tremendous poverty and widespread neglected tropical diseases. Or northern India, or northeastern Brazil, not so much in Rio de Janeiro and Sao Paulo, but going up into Pernambuco state or into Recife, widespread disease and poverty, or northern Argentina, or as we'll hear a little bit later, in southern Mexico. And in fact, it's the G20 countries that now account for 50% of the world's worm infections, most of the dengue, most of the Chagas disease, most of the leprosy, and about half the world's AIDS, TB, and malaria. So what's happening globally, I think, is we're seeing a paradigm shift. This concept of developing versus developed is morphing into all economies rising, but it's leaving behind a bottom segment of society. And we've given this a new name to distinguish it from global health, calling it blue marble health, the big blue marble that was taken by the Apollo 17 astronauts as they were circling around the moon. And it's very important because I think it provides a new framework for thinking about science policy and global health policy, because it says that if the leaders of the G20 countries would redouble their efforts to their own neglected populations, we could wipe out half to 2/3 of the world's neglected diseases. And so it's not a resource problem always, as we always think about it, but it's a political will issue. So that brings us to here. What's going on here? Do we have poverty in the U.S.? How much poverty do we have in the U.S.? So we have about 40 million plus Americans that live below the poverty line. But the two numbers that intrigue me the most are the fact that we have 20 million Americans who live in extreme poverty, that is at 1/2 the U.S. poverty level. And now new numbers coming out of the University of Michigan Center for Poverty show 1.65 million families living on less than $2 a day. So the same metric you can use for global poverty anywhere you can find in the United States. And guess where most of the poor people live? The South. Anyone want to venture in a little more surgical precision here? The state of Texas has 5 million Texans living below the poverty line. So I got when we came down here, I remembered a book that I had to read in high school. I don't think I appreciated it much at the time, but somehow it clicked and resonated with me. It's this book called The Other America, and it was what incentivized John F. Kennedy and later Lyndon Johnson to launch the war on poverty in the United States. And I think he says it so beautifully here. He says, to be sure the other America is not impoverished in the same sense as those poor nations where millions cling to hunger as a defense against starvation, this country has escaped such extremes. That does not change the fact that tens of millions of Americans are at this very moment maimed in body and spirit, existing at levels beneath those necessary for human decency. They are without adequate housing and education and medical care. And that caused me to say, well, knowing that wherever we find poverty, we're finding NTDs and vice versa, let's look. And so I did a 25-year literature search and published it in the Public Library of Science again, and it was called, the original title was Neglected Infections of Poverty in the United States of America. And here's what we came up with. We came up with the fact that there are 12 million Americans now living in poverty with a neglected tropical disease. And here are the major players. Chagas disease, cysticercosis, Toxocariasis, trichomoniasis, and we also have some arbovirus infections. And so I got very excited by this and thought, wow, this is going to be amazing, because after working so hard to get NTDs on the radar screen in places like Africa and Asia, what happens when we talk about 12 million Americans living with a neglected tropical disease? And so far, the results have been sort of a dud, to be honest, and this is one of the reasons for this conference. So let me give you an example. So Ebola was very good for my TV career. So during October and November last year, I was on either MSNBC or Fox News every day. And that's not easy to go from MSNBC to Fox News and back. And so, but the response was always the same, because the question was, doctor, especially after we had the case of Ebola in Dallas, and then the two nurses, the question came, doctor, aren't you terrified about Ebola virus now gaining a foothold in Texas and there being an epidemic? And I would answer no, because we know how this disease is transmitted. We have the health system infrastructure in place. But we do have 12 million Americans living with a neglected tropical disease. And of course the answer was, well, thank you, doctor, we're out of time. And it didn't matter, who it was. It didn't matter if, this came from Al Sharpton at MSNBC, said, thank you, doctor, we're out of time. And it was the Mean Girls on Fox News. It was, thank you, doctor, we're out of time. It didn't make a difference. It was an inconvenient truth. And so we got this in the New York Times, and the first response was how quickly people politicize a health agenda. So of course the people on the right wanted to talk about the fact that these diseases must be slipping in across our southern border and we need to build the wall higher. But then I would point out the fact that we have 10% of the dogs are infected with Chagas disease in Texas. The dogs are not slipping in across the border from El Salvador and Mexico. We have this disease transmission here, and maybe Christy Murray is going to talk a little bit more about that. At the same time, the people on the political left have their own agenda. I was really, when you go write an article for the New York Times, one of the things you learn is it's not a straightforward process. It's very iterative. You go back and forth with the editor, and one of the things that I found was very interesting was the editor really wanted me to pin this on Governor Perry, that when I wrote this article at the time, that it must be Governor Perry's policies. And I said, look, we have evidence from PCR and mummified remains from the Rio Grande Valley that this disease has been here for over 1,000 years. I know he's been governor a long time, but he hasn't been governor that long. So what are we talking about here? So this is, you can take a drive here in Houston and just go a few miles to, say, the Fifth Ward, which is a historically African-American neighborhood in Houston. This is what you see. You see, and this is trying to understand why we're seeing neglected tropical diseases here. So, for instance, when Christy Murray did some work to look at dengue, and she found that dengue was disproportionately hitting areas like the Fifth Ward. What is it about the poverty? Well, this is what the Fifth Ward looks like. This is a picture taken by Anna Grove, who's in our group, and you can see the dilapidated housing with no window screens. So that's a tip-off. Or the standing bodies of water, or the discarded tires along the side of the road that are filling with water, or open sewage, or packs of stray dogs, and these kind of give you a sense of what's going on here. So. We're now really trying to do a deeper dive to really understand the transmission patterns for these diseases and what we can do about them. So I'll just talk about a couple for right now. So Chagas disease, named after Dr. Carlos Chagas, who was a Brazilian scientist who uncovered, working at the Oswaldo Cruz Institute in Rio de Janeiro, was working on in rural Minas Gerais and worked out the whole life cycle of the disease at the turn of the 20th century. So our team at the National School of Tropical Medicine has been doing a deep dive and finding evidence for what we call autochthonous transmission in Texas, meaning with the CDC and their reports are primarily focusing on disease importation. What we're finding is a significant level of transmission of this disease within the state of Texas, and trying to better understand this. So this is Christy Murray here, and her graduate student Melissa Garcia, and Job Lopez on our faculty looking at vector-borne transmission, and Lila Colburn now has a tropical medicine clinic where she's seeing Chagas patients. And it was interesting when they were tracking down blood donors who were donating blood and found to have Chagas disease, and then told to go see their primary care physician, who then told them that, we don't have that disease here, it must be a false positive. So they tracked them down and are finding a significant level of disease. And then working with Dr. Bruce Lee, who I hope will be speaking this afternoon. It's different Bruce Lee. We can do now some estimates of the lost healthcare costs due to Chagas disease, as well as lost worker productivity. So $7 billion globally, but $864 million in lost economic productivity in the United States. And I would say at least half of that's in Texas. So we're talking about a lot, $500 million in economic productivity loss to the state of Texas. So one of the things that we're doing about this is really trying to develop new interventions. And we have this problem in that we don't have the right organizations in place to address innovation gaps. And we saw this with Ebola virus infection, where we didn't have a vaccine until it was too late, when there was no more Ebola. And that was not because the technology wasn't there. The technology had been published a decade ago, but the business model is broken. It says that an academic researcher identifies a promising technology, and then it sits there in the biomedical literature and waits for a big pharma company to license it. Well, of course, that didn't happen with Ebola, and it's not going to happen with diseases like Chagas disease. So one of the things that we're doing now is looking at these 16 product development partnerships. These are nonprofit organizations that use industry practices to make either diagnostics, therapeutic products, which are small molecule drugs, microbiocides and preventatives, or vaccines that target neglected tropical diseases and other diseases of poverty. And our Sabin Vaccine Institute is the only one based in Texas, and it's based at Texas Children's Hospital and Baylor College of Medicine, where we're developing now a generation of these neglected tropical disease vaccines that the big pharmaceutical companies can't make or won't make. And it's based in the Feigen Center of Texas Children's Hospital, and I would encourage you to come and visit us if you can. And one of the things that we do is we're doing all the things that a mid-sized biotech company does, and this is Mary Elena Batazzi, who is leading a lot of those efforts together with a team of scientists. We have some of them here, Uli Stritch and Kareem Beaumier and Portia Gillespie, who are doing all of the things which include quality control, quality assurance, to actually develop the vaccine and then submit it for investigational new drug application. And we now have a very exciting bivalent Chagas disease vaccine, which we had a press conference this morning with Dr. Roberto Tapia from the Carlos Slim Foundation, who is now helping us develop this new vaccine. We also have support from the Clayburgh Foundation and the Southwest Electronic Energy Medical Research Institute. But through a Carlos Slim initiative, now we have this bivalent vaccine to develop. And it's our first vaccine that might be used in the United States. So when we came down to Houston, we were thinking about making these innovations for Africa and Asia. But now, after what we've uncovered, we're now developing vaccines for the poorest people here in Texas, and our Chagas disease vaccine is a good example of this. And what's one of the great things about being here in the Texas Medical Center is the level of innovation here is just extraordinary, especially when it comes to heart disease, and Chagas is a major cause of heart disease. And so the great thing about the Texas Medical Center, anywhere you throw a stone, you'll hit a cardiologist or a cardiothoracic surgeon, and it's just an amazing center of heart disease research. So Jonathan Respris in our National School of Tropical Medicine has now been imaging, using the imaging facilities that are available here to actually model the effect of Chagas disease in small laboratory animals. Now, I know you're not mouse cardiologists, but I think you can see just by the EKGs some of the that we can reproduce a lot of the abnormal heart disease of mice. And Jonathan's even taken it a step further by doing, I don't know if I can control this, or let me see if I can do this here. By doing this by echocardiogram. So here's a normal heart. I know you're not mouse cardiologist, but you can see that here's a normal beating heart of a mouse. And now we can compare that with a mouse with Chagas disease, which looks just like the advanced human disease, where the heart will stop beating for periods of time. It's a big dilated heart. And these are all the things that you will see would happen with a poor, unfortunate individual. This is not a rare disease. We're talking 10 million people in the Western Hemisphere. and tens of thousands, if not hundreds of thousands of people here in the state of Texas, and now looking at the impact of that vaccine. This is not the only disease that we're finding. Another one that's of great concern is this one called Toxocariasis. It's a parasitic worm infection that's transmitted from dogs. So if you go through the Fifth Ward of Houston, and elsewhere in poor impoverished areas in our city, you will see packs of stray dogs, and those packs of stray dogs are defecating, releasing millions and millions and millions of Toxocaria eggs, which are shed in the environment, and kids come into contact with them and swallow them, and those larvae hatch, and they migrate through the lungs, and they cause asthma. They'll migrate through the brain, and they'll cause cognitive and developmental delays, and they'll actually shave IQ points off. The Center for Disease Control now estimates that 20% of African American kids who live in poverty have toxocariasis. So the question then, again, not a rare disease, so of the 12 million, 2.8 million is coming from toxocariasis. So we asked a very important question. This is the Fifth Ward again here, and there's a lot of effort to do something about all the stray dogs in the Fifth Ward. But the point is, I wrote this article, very provocative article, admittedly provocative article in JAMA Psychiatry, my first paper in a psychiatric journal, that basically said, if 20% of African American kids are living in poverty of Toxocaria, and Toxocaria has been shown to cause developmental delays and IQ deficits, what proportion then of the achievement gap that's been noted among socioeconomically disadvantaged kids might actually be due to a parasitic infection? So we're now trying in our Sabin Vaccine Institute and Texas Children's Hospital Center for Vaccine Development, Ben John and his colleagues are actually working to develop a new diagnostic. One of for this to really and to have this as point of care. One of the reasons why these diseases are so ignored is it's very hard to do a diagnosis in these diseases. When you go for blood work and to your doctor wants to do laboratory tests, you want to do blood work, he gives you that slip from Quest Diagnostics, and you see a little box for blood glucose, a little box for the chemistries, a little box for your white blood cell count and your red blood cell count. Well, there's not a little box for Chagas disease, right? There's not a little box for Toxocaria. That's because it has to be done at specialty laboratories at the CDC or in our lab. So the point is we need to make these more accessible. So we're trying now to create a diagnostic kit where the pediatrician in real time can actually get an answer of what's going on with Toxocaria. Cysticercosis is another important neglected disease hitting our state. This is a brain parasitic infection that's linked to epilepsy, and it's not as prevalent. We estimate around tens of thousands of cases in the United States, but at our tropical medicine clinic that Lila Wack-Colburn and Rogelio Mejia go to, is attending every day, they're seeing patients every Friday with cysticercosis, so it's an important cause of epilepsy. And Houston is also blessed because we're at the confluence of poverty and the world's largest port, and we also have a warm subtropical climate, and we're very lucky with having two Aedes mosquito species, Aedes aegypti and Aedes albopictus. Aedes aegypti is particularly efficient at transmitting things like dengue and yellow fever, and from Christy you're going to hear more about the Aedes problem that we're having and the risk of our city to dengue fever. So the Chamber of Commerce really likes me a lot, but I think we have found something very important that, and it's really a good example of blue marble health. It's widespread disease among the poor, and what we're now finding is we have a lot of opportunities to invent new technologies for these diseases, which is what we're doing here in the Texas Medical Center. But the point is, in some ways, the technology is the easy part, because unless you have the political and social and financial instruments to get these actually developed and used, it's just useless knowledge that sits there on the shelf. And this is why we have this association with the Baker Institute, because we need a policy for this. So it's the same thing with the Ebola virus infection. We had the technology, but we didn't have a vaccine because there was no policy to shape around it. We've got the same problem in the United States, and we're hoping now to really take this on in a big way. So I'll stop there, and I don't know if I have time for a couple of questions, or somebody's nodding yes? Okay. Good. So I'll stop there and take a few questions. Thank you. Yes.
I think this is kind of a two-part question. You alluded to saying exactly, the Rio Grande Valley. I know there's actually even Michael Bloomberg and NPR did a series on poverty and surprise here in Houston. But why isn't that, especially you got the Colonia factor down in the Rio Grande Valley, and you showed it like in the Fifth Ward, which is exactly like Colonia. Why hasn't more field work been done? And then to what you alluded to about the business model, the love that the Chamber of Commerce is giving you, what does that factor like? Sometimes over academically theorizing, what actually is in place.
Yeah, I think so. There's two parts to that. So I think one is the issue on return on investment. There is a return on investment, but it's not a conventional return on investment. It's improved public health and lifting people out of poverty. So it's kind of 2 degrees of separation for the investor, and so it's kind of difficult for people to understand. Also, I think this concept that we have widespread neglected diseases among the poor in Texas, I think is still a new concept. We're just now kind of getting the word out there, and later you're going to hear from Senator Sarah Davis from Texas, who's going to talk about what she's been doing now to create the first piece of legislation in anywhere in the country on neglected diseases, and it's happening here first. So we're now starting, but we're still at the early stages. Thanks for that question. Yes?
Excellent presentation. I was curious to know and see that in the Millennium Goals, HIV and malaria listed, and tuberculosis somehow has been sort of like dropped or not. So I wanted to get your reaction on where is tuberculosis in this?
So what happened was, you're not the first to make that observation, and it's an accurate one. So I think what happened quickly after this was done, people created the big 3 diseases, AIDS, malaria, and TB. So TB did get in there, and there was big global initiatives. And we've been able to look at the impact now on tuberculosis. If you look at that title of that paper, it includes AIDS, malaria, and tuberculosis. So there has been an impact on tuberculosis, but we still have the problem of multi-drug resistant tuberculosis. We still have the problem that we don't have a tuberculosis vaccine. So there are at least 2 product development partnerships on that 16 that were launched specifically in response to TB. So TB is an important one. Interestingly, there's a lot of interest, not a lot of interest, there should be a lot of interest in TB here in Texas, because one of the observations, especially in the Rio Grande Valley, has been made by Joe McCormick and Susan Hawk-Fisher, who are a husband-wife team based at the University of Texas at Brownsville. What they're now seeing is a unique syndrome down in South Texas of tuberculosis in the setting of diabetes. So, we're seeing this interesting confluence between, or merging between NTD, not to bury you with acronyms, NTDs and NCDs, non-communicable diseases. And I think this is not unique. What we're seeing, for instance, in India, we're seeing dengue superimposed on diabetes. And we're going to see effects on hypertension and heart disease and cancer. So I think we're going to this is going to be kind of the next wave, looking at the confluence of neglected tropical diseases and non-communicable disease. Yes?
Peter, do you think that poverty is understood the same way in developing countries as in the U.S.?
I'm not sure poverty is understood anywhere. So I mean that seriously. Because one of the things that we're not seeing enough papers on is we know there's a link with poverty, but the mechanisms are still very theoretical. I can show you that picture of the Fifth Ward, and we can make some good guesses, make some good hypotheses of why poverty is linked to neglected tropical diseases. But actually proving it has been, I just don't think there's been enough effort to really look at why poverty promotes neglected tropical diseases. And also we need better metrics on showing how neglected tropical diseases reinforce poverty. It's a great question, though. Okay, well, thank you very much, and I understand we're going to take a break. Is that the plan? Okay, we're going to take a brief break, and then you're going to hear from the Ambassador Dejerian, and then from Mercedes Juan Lopez, who's the Secretary of Health of Mexico. So thank you for coming this morning.